This will definitely be on the test, though, which is mechanics of breathing, which is covered by Chapter 7. Okay? When you look at the way you breathe, there's really two sets of muscles groups. You can have to call it, you can break it up into inspiratory muscle groups or expiratory muscle groups. The expiratory muscle groups, and the majority of the time, are basically passive. So they're really not doing a lot of work unless you're running. Okay? On the other hand, inspiratory muscle groups are working all the time. Okay? And the majority of the inspiratory workload is done by the diaphragm, okay, which is the most important muscle. The diaphragm is a very specialized muscle in the sense that it's kind of a strange muscle, that it doesn't have a linear connection. It's not like skeletal muscle if you think about it. Skeletal muscle is connected up to bone, and that's what it moves you in only one direction. Diaphragm, on the other hand, is a radial muscle, okay, which is a center point, which is the middle of the diaphragm, and then it has muscles coming off it, and it can actually push in different directions, which makes it a very different kind of muscle. But it's still a muscle after all. And what makes it kind of interesting is that we didn't know this until a few years ago, is that most of us thought in the 80s that the diaphragm was a fairly stupid muscle. In other words, it just sat there and just contracted and did its job. And we're finding out that it's, of course, a lot smarter than we think it is, just like we are pretty stupid in that sense. There's constant information coming back to the brainstem. And these are coming from somewhere, and that information coming back from the diaphragm is from spindle muscles. So there's specialized sensors inside the diaphragm that tells it its position in space. That's pretty cool, think about it, okay? Now, what's interesting about it is that these spindle fibers have different frequency response curves, and depending on which portion of the diaphragm you're looking at. Okay, so if you were to take a piece of tissue of diaphragm and play with it experimentally, and you took another piece, you would actually get different values. And people didn't say, well, why is that? And the answer has to do with that the diaphragm is not straight. It's not a straight muscle. It's actually a domed muscle. And certain portions of the dome have more stretch effect, and maintaining that contraction at that point is critical for the muscle to work properly. Okay? I'll show you a picture of it here in a minute, but when you show the picture of the diaphragm, it's actually a lot more involved than what it appears, and we'll come back to that in a second. The major nerve that controls the diaphragm is the phrenic nerve, which is C5. It's actually a combination of three nerves, C3, C4, C5, being C5 the most important part. Okay? And that invariably sends fibers down to the actual diaphragm. And the right phrenic nerve controls the right diaphragm, and the left phrenic nerve controls the left diaphragm. So in other words, you can have one diaphragm paralyzed. Okay? One side can become paralyzed in comparison to the other. And it happens pretty frequently in the operating room when we're doing blocks. When we do an interscaling block on somebody, we can basically induce paralysis in that phrenic nerve, and then that diaphragm stops functioning. So in essence, we're basically down to maybe a third lung function properly. Even though this side is only contract, the other side will still follow with it and still get some effective ventilation taking place. It's not like you're losing the whole lung, but it's still going to make you a problem. So if somebody has bad COPD and is really marginal, should you do an interscaling block on them? You have to be very careful. Okay? And please don't do one thing, which I saw one of my attendings do. He told me one day, he says, Doc, John, he says, I am so good at doing this. And I'm going like, oh, I hate when people say this kind of stuff. And he was bragging. And anytime you got bragging, you're going to find somebody else that's going to whack you. So I was sitting there watching him and going like, you're going to do what? You're going to do bilateral interscaling blocks? Because this guy's going to have 2 shoulders done? I don't think that's wise. And he goes, well, it's okay. They'll be fine. I never knock out the phrenic nerve. It never happens. So I got to sit there and watch them do it, because I told him, you know what? He says, you're an expert. I'll sit back and watch you do it. He says, I am just a lowly little resident. Okay? And that's the best way to be at that point. Just be the little ant. Okay? So he did the great blocks. This person had no movement of his arms. He basically all of a sudden he couldn't move his arms. And then about 15 minutes into it, I started saying, how you feeling, sir? And he stopped talking to me. And I looked at him and said, are you okay, sir? I'm going, oh, this is great. So I call my attending back while I'm beginning to ambu bag the guy. And said, I think we better intubate this guy. Okay? He couldn't talk. Why? You can't scream in space. Okay? If you can't move air into your lungs, you cannot form a sound. Okay? His both diaphragms paralyzed, and that was it. Okay? So a good thing is we were able to ventilate the guy, then we're able to put him to sleep, and then we intubated him. And then we had to keep him on the ventilator for 48 hours. An outpatient procedure. Yeah, the patient was real happy, right? ICU stay for 2 days, a little bit of a recall about not getting oxygen in you. It was so pleasant. So not something you should ever do, okay? What you have to accept if you do an interscalene block is 100% knockout of phrenic nerve. Never get so complacent to believe that you're that good. That's what I'm trying to show you, okay? And this is a guy that does it, that believes everything should be used. A needle, there's certain kinds of people in anesthesia. They can have some people that love general, some people love needles. So this is one of the needle guys, needle drivers. Here's what the diaphragm will actually look like. And what they're finding out is that these diaphragms that are here, this area right here, where the actual angle is its greatest, has the greatest number of spindle fibers. And the greatest amount of back information is coming back from the medullary area of the brainstem. So when you put people to sleep, what happens to this portion of the diaphragm? The sensory information goes away, and then it cannot maintain shape, and basically you lose 20% of your FRC. That's where it's coming from. So it doesn't really matter how you put them to sleep. If I put in local anesthetic into your nerve, that's sensory information back, this would be equivalent as inducing you with general anesthesia. So it doesn't really matter. Okay? What's cool about it is that the diaphragm is very efficient. Okay? And under normal circumstances, it can carry, it basically never gets exhausted and basically maintains your breathing for the rest of your life. Every once in a while, the diaphragm will get additional assistance from the expiratory, what's called the external intercostal muscles, which assist inspiration. Okay? What you have to think about is the externals lift the chest to help maintain your breathing. So that's the externals. If you look at paralysis of these muscles, which occurs at dermatomal levels, you really don't get any symptomatology until you get to phrenic nerves get knocked out. Well, that being said, most people don't particularly like it either. Okay? I've had people that will freak out once they get a spinal and they can't feel their chest moving. Some people like to feel that their chest is moving, and they will freak out on you because they'll say, I can't breathe. Okay? Now, as soon as you see somebody screaming at you that they can't breathe, first of all, you're safe because they can breathe because they're screaming at you. Okay? It's when they're trying to open their mouth and they have nothing coming out of it that you better be on top of that patient immediately, because now you really have phrenic nerve paralysis and you got big problems in your hands. That can be happening from a high spinal. But how do you eliminate somebody from freaking out once they feel that your chest wall is not moving? How do you stop this negative feedback that this person is having? You can sit there and try to explain to them, hey, you're breathing, you're talking, so you're fine. And they'll look at you like, what? I still can't feel my air. You know, I still can't feel like I'm breathing. So the way you can terminate this anxiety is bring up their hand, bring it up with their face, and tell them to breathe out. As soon as they feel the air hit their hand, the anxiety disappears. They'll stop freaking out. Okay? And then you put the hand back down and make sure that the person's level is not going up any higher. Okay? But that's the first thing you do. If that usually will terminate the fear, and then the person will calm down on you. Okay? The other muscles of inspiration are the accessory muscles in the neck. Okay? So the neck will actually lift up the clavicle up to make you breathe better. If you look at Christopher Reeve before he got injured, or after he got injured from his fall, and we had a C2 quadriplegic injury, if you look at his neck in comparison, 7 years later, his neck was 10 times the size. Pretty large and pretty impressive. Why did he do that? And the answer is he was totally ventilatory dependent because he had a C2 quad. So he could not use, his phrenic nerves couldn't function. So anytime he wanted to be off the ventilator, as soon as they took him off the ventilator, he couldn't breathe. Okay? What you do to train people with C2 quad injuries is you can train them to use their accessory muscles in their neck, which is the sternocleidomastoid, the platysma muscles, to take in a breath with using their neck muscles. So they get these muscles that have become hypertrophy and they're huge. Okay? So it's really impressive how big their muscles are. And they're able to maintain ventilation for about 6 hours, if they needed to, without the ventilator. What ends up happening, unfortunately, is because the diaphragm is no longer functional, the diaphragm just keeps riding up and FRC drops off to a critical value, and then you get saturation. Okay? But that means that person could take a shower without being on the ventilator. It really makes a difference between the person having some degree of freedom from the ventilator just for a short period of time without having to freak out, in case you lose battery power or something like that. So he was working to trying to breathe. That was his big thing. He tried to work at it for almost several years. And, people kept telling him, go ahead and try. But, physiologically, you cannot maintain for more than 6 hours because of the FRC issues. Okay? Now, the other muscles, on the other hand, for expiration, normally are passive. So chest recoil usually does a very good job of trying to expand outwards. But the lung is always trying to retract. The lung is going to let you basically exhale properly because it's collapsing inwards. The other thing you can also do is that you can use your abdominal muscles to actively exhale. Okay, so contraction of abdominal muscles like the rectus abdominis, internal and external obliques, and the transversus abdominis all help. So if you see somebody who really has to do a lot of aerobic work, they really have six-packs for abs, so boxers. People that really are breathing really hard all the time. You'll see that they have very extensive abdominal muscles for that reason. Runners are also always have very nice, tightly packed abdominal muscles as well because of the effort of breathing. If you see every once in a while somebody who's learning to run, you'll see that they'll have pain on their side. And the reason they're having pain on their side is because one of their external obliques are usually going anaerobic. It could also occur from right ventricular failure. From pushing yourself too hard, the actual liver gets enlarged and gets congested, and you get abdominal pain from that as well. So you got to sort of figure out which one it is. If it's only on this side, it's most likely liver congestion. So you need to stop. You're overdoing it. Okay. If it's both sides, then you're just using your external obliques too hard. Okay. Yes, you had a question. For diaphragm for exhalation, it doesn't do much for exhalation. It's very inefficient. Diaphragm is mostly for inspiration. The diaphragm during expiration goes passive, tries to relax. It doesn't go completely passive because if it did that, the lung would completely collapse below FRC. So once it's approaching towards FRC, the diaphragm will start contracting and stabilizing it to stop it from going down too low. Okay. The internal intercostals are also important for expiration. So when you look at breathing, it's a passive movement, not passive movement, it's an active movement of the diaphragm going downwards, which then causes air from the mouth coming in because of the negative intrathoracic pressure that creates it. And then you have your passive expiration, which is just basically from the relaxation of the diaphragm that takes place. It's a nice little picture. I actually have a three-dimensional one. I'm going to show you here in a little bit. I'm going to come back with that. Yeah, I'll come back to it next week. I got this software the other day. I'm going to put it on I have it on iPad. You can actually see the lung that's moving it up and down. Now, what you do see is that the lung does not deflate as fast as it inflates. That's kind of strange. That's called the hysteresis curve. Okay? The reason for that is because the surfactant in the lung is very important to prevent the lung to completely empty its volume. It's really trying to prevent that from happening. So hysteresis is a way of describing this difference in filling of the lung as well as exhalation of the lung. Okay? What you want is basically you want to have a system where you have rapid filling, okay? But at the same time you want to have a system with slow emptying. Okay? You don't want the lung to empty too fast. If you look at this curve, this is a normal inspiratory, expiratory curve. Okay, you see down here is a pressure, okay, and this one is the actual tidal volume or movement of gas. If you look at this person is on inspiration for delta P of, let's say, plus 10. You get a rapid increase in tidal volume almost immediately. But then on exhalation, there's almost like a delay factor here. Okay? See this flat, this curve is a little bit flat here. And then it flattens out even more down here where it becomes more difficult to exhale. Okay? So this person basically, and all humans basically have this ability to have a different curve from inspiration as well as to exhalation. Now, the way they actually figured this out is they took a normal lung and they inflated it, and they got this kind of curve out of it. This is fine, okay? Now, if you look at the curve on the top, okay, see this right here? See how it flattens out? That's something you don't want to see, okay? Because if you see pressure rising without any change in volume, what does that mean? That means you're beginning to tear the lung apart. Okay? Because you're actually increasing pressure without changing volume. And so at that point, the lung is overstretched and doesn't want to give anymore. When we actually do this in cases, we're actually looking for a pressure curve that looks like this, flat. And that's called the beak sign. Okay? It looks like a bird over here, the bird beak. Okay? You don't ever see that. That means that the pressure is rising without changing volume. If you're doing that, you're over-distending the lungs, and you're most likely going to cause volume trauma, which is you're actually causing shear forces to affect the lung and damaging it. Now, can you make the hysteresis curve disappear? The answer is yes. I can take a lung and dump it in salt water and then pull it out and then reinflate it, and then the curve looks just the same as inspiration as exhalation. What did I do when I did the salt water? What did I do to the lung? If you look at the salt water, it's got a bunch of, like an oil on the top of it. I washed out the surfactant. Okay, so the surfactant is critical to keep the lung from collapsing. Okay, you don't want the lung to collapse. The lung wants to stay open and not stay fully to collapse, which is why this curve is flatter here, because it's allowing the lung to stay open for a longer period of time. It allows change in volume to let gas come out. Okay? It also prevents you from going towards complete collapse. You don't want to have your lung completely collapse, because then you have to restart and reinflate the whole lung all the way from the start again. So your pressure volume curves, when you look at the inspiration, it's more difficult to expand the lung. The curve is nonlinear. The lung becomes stiffer at high volumes and low volumes. So if you look at this picture down here, this is the inflection curve. And this is the inflection part of the curve too. So both these places are bad to start with. Okay? If you're looking at the bottom of the lung, that's where the bottom of the lung would be, and this would be the top of the lung. Diaphragm is opposing the elastic lung, which is trying to collapse. And the compliance is the slope of the curve. Okay? So it's how healthy that individual is. Okay? So if you have a decrease in compliance, which means you have less volume for a greater change in pressure, that's a bad thing. That would be equivalent to somebody getting wet lungs, such as pulmonary edema, and the actual slope of this curve would become more like this. This curve would shift this way. Okay? It would become flatter like that. So this curve is going to shift from this angle to this new angle here. That's what they're trying to tell you in the book. Does that make sense? So that's a reduction in compliance. Okay, on expiration, the lung basically is trying to stay inflated. The behavior depends on structural proteins as well as surface tension proteins and lipids, which are surfactants. So let's look at the different components that are inside the lung structurally. You have inside your lung mostly elastin. Make sure you understand that. Do not answer collagen. Collagen is not what's in the lung. It's elastin. Okay? Collagen is what replaces damaged lung tissue that had elastin in it before. Collagen is really bad in your lungs. Okay? It makes you too stiff, and it makes you cause restrictive disease. Okay? But elastin is a very specialized protein that is able to expand nicely, okay? And it's got cross links and then is able to relax into this kind of bundle, which basically gives the lung its ability to contract or retract all by itself. It's like having basically rubber bands attached inside your lungs to keep you intact. You can damage these guys and break them, and when you break them, what happens? You form COPD, or emphysema. Okay? If you add more rubber bands to this, then you get restrictive disease. Okay, does that make sense? All right. What happens if you fill the lung with saline? Well, the first thing that happens is that you begin to lose your compliance curve. You lose that hysteresis curve. If you're air-filled, the hysteresis is large. On inspiration, you have low compliance, and more pressure is required to expand the lung. Okay? On the expiration side, the lung tries not to collapse, and surfactant acts to prevent collapse, and residual gases also act to prevent collapse. And the residual gas that's important there is nitrogen. It's not CO2 and it's not oxygen. It's really nitrogen. Yes, sir. Yeah, it's negative. There's reasons for using it, though. But you don't want to pour saline into people. Like bronchoscopy, right? What happens after bronchoscopy? Do people get better or they get worse? They get worse. They get a lot worse. And the reason they get a lot worse is because you're causing atelectasis to occur much more rapidly. You're suctioning, and also you're pouring a bunch of salt water in there, which is you're washing surfactant out. And the person collapses at a faster rate as a consequence. So bronchoscopies that are considered therapeutic are still negative for the first hour or so. Okay, then this person starts improving, because the way the therapeutics improve is because you're able to wash out the mucus. If your bronchiole is completely inspissated, which means that there's mucus all the way through it, then there's no air behind it. Okay, so by washing that out, then you'll have a chance to get re-expansion of the lung. Okay? Now, I've been in situations where everything is going bad, and the pulmonologist is going like, "What are you doing now?" I mean, and I usually at that point will re-expand the lung. Okay, after he's washed everything out, then I re-expand the lung actively, instead of waiting for the person to do it by themselves by coughing or deep breathing. So what I'll do is I'll put my mask on the patient, and I'll close my pop off, and then I'll create 40 centimeters of water pressure to pop open the lung. And all of a sudden the saturation, boom, goes up, and everything gets better. That's a good way of getting yourself out of trouble, especially when you're sitting at saturations of 84, 85%. If you wait for them, you're going to wait a good hour, and during that time period, you might be too hypoxemic and not be good. Okay. So consider doing that as well. You usually have to do it 2 or 3 times, but usually the first time is the most important in the sense that you'll see almost immediate response. So you'll see the saturation immediately jump up within 30 seconds. The first time you do it, your sats actually falls initially. Don't freak out. That's because you just opened areas that were atelectatic before, so PaO2 values there were very low. Okay. Then when you re-expand the lung, now you get reshifting the blood back to areas that are being properly perfused. Okay. So saturation will then jump 30 seconds later after that. Okay. Yes. Right. Well, they're doing, for transplants, you're doing several things. One is you want to do tissue samples for transplants. You want to see if the person is going through rejection. Okay, there's obliterative diseases that are from the transplantation, okay, where you have to do biopsies to make sure the person's not rejecting. If you are getting positive rejection signs, then you up your dosing to immunosuppress that individual further. If, on the other hand, you go in there with doing a bronch and you see that the person has a very bad infection, then you've got to aggressively treat that. So it depends on the situation and why the bronchoscopists are doing it. They're usually doing it for either staging or finding out if the person has an active infection. Okay? If you're doing a non-transplant patient, why you would be doing a bronch was, most of the time we're doing it for either diagnostic purposes, for if the person has some kind of carcinoma of the bronchioles, or the majority of the time when we're doing it is therapeutic, which is for mucus, excessive mucus production. Okay, somebody with maybe have underlying bronchitis, and they have so much secretions that they can't clear them. So we actively go in there and empty out the mucus from the bronchioles. We actually will suction it back and pull the stuff out. And it can be amazing how much we get out of the patient. So in that situation, that person should get better, not worse, usually. But it takes several hours for them to get better initially, unless you do the inspiratory hold maneuver that I was just saying. Okay? Yes? Mm-hmm. No, it depends on the duration. The duration of how long you keep the pressure going. If I generate 20 centimeters of pressure on you, you will basically cardiovascularly collapse if I do it for 30 seconds. So at lower pressures, you can be in a bad situation. Okay, and I try to teach that when you get to clinical to stop doing that. A lot of people forget to open up the pop-off once they get the patient intubated. Okay, and the pressure goes up to 20 and they're not realizing it. And then they're doing other things like they're taping and they forgot to turn the ventilator on. And now the blood pressure, when they first check it, now the blood pressure is 80 and they're still not ventilating the individual. Well, the reason that the cardiovascular collapse is now you've prevented all the venous return to come back from the heart. That's different. Okay. Now, will 20 centimeters of water pressure rupture a lung? No, it won't. It won't. Okay. Will 40 centimeters of water pressure rupture a lung? No, it won't. Okay. Unless you push it in super fast, which is a possibility of doing that, but that's unlikely. And where do you get barotrauma? It's around 50. That's really the critical value. 40, you're getting up there. That's where the margin of safety needs to back off a little bit. If you're doing a kid, 40 is a little bit high. You don't want to be that high. So in adults, around 50 is what we consider critical. You don't want to get above that. Because 50, you start basically, you can rupture the trachea and the bronchioles. Okay, that's where we have to worry. Okay? But for lung itself, no. If you hold pressure for 7 to 8 seconds, you're not going to have a hemodynamic effect. You're going to re-expand the lungs properly, and you're going to be safe. You're not going to cause a problem. Okay. So, you have any questions about anything else on that? That's an important question because a lot of people, when they hear that number, they don't use it because they hear this thing about barotrauma that, oh well, you know, if I hit 40, I'm going to cause the person to collapse their lungs or something like that. No, you're not. That's the only way they re-expand the lungs. So there is no other way to do it. But keep it under 7 to 8 seconds. You know, the old recommendation was 15 seconds. We've already gone away from that because it causes too much hemodynamic compromise at that point. So 7 to 8 seconds is plenty of time. Okay. Now, if you take the same lung and you fill it up with saline, okay, which is water filled, and then you wash it out, then you take the saline out of it, okay, you basically wash out all the surfactant. And as a consequence, the hysteresis curve almost disappears. Okay? So in that situation, inspiration, you have high compliance, and expiration, nothing to prevent the lung from collapsing. So you have no surface tension, and you washed out all the surfactant. So you get a rapid collapse rate in the lung, which is detrimental, and it requires a higher pressure to get volume into the patient in the next breath. So this is the difference. This is a person that's air-filled, okay? And this is a person who gets saline and it's washed. You can see there's no difference between the inspiratory and expiratory curve, and because of that, you have much more problems, okay? For this person to generate, this will cause this big problem in collapsing the lung, and to really expand the lung is going to be a big problem in the long term. So hysteresis is due to the presence of lecithin surfactant, and the surfactant has a hydrophilic head and a hydrophobic tail. The hydrophobic tail is fixed to the alveolar wall. Okay? The hydrophobic tail is facing away towards the alveolar airspace. Okay, so it's keeping things dry. The hydrophilic head, on the other hand, is fixed to the alveolar wall. Okay, it interacts with water, disrupting hydrogen bonds, and lowers the surface tension. At low lung volumes, the concentration of surfactant tends to increase, so surface tension decreases, and it keeps the lung from collapsing. At high lung volumes, concentration of surfactant decreases, so surface tension increases, which is going to make the air less go into that area. Now, what we see that is a little bit more complicated in this, as we're finding out, is that surfactant is not only made up of lipids, but it's also made up of specialized proteins that we're finding out. Okay, And these proteins can actually change their shape. They can restack, they can stabilize. They do some interesting things. We talk about this in the DNAP for about 45 minutes, so if you guys want to get to that point, you can come back and listen to that another time. So, but just for now that the lung doesn't want to collapse because of hysteresis, because of surfactants. On inspiration, the surface tension is directed inwards because water molecules on the alveoli are trying to interact with each other and keeping the lung trying not to collapse. And on expiration, the surface tension is directed outwards because the water molecules on the alveoli are pulled towards the bulk water outside the alveoli. This opposite force creates this elastic loss known as hysteresis. So this is what they show you the picture of it. Okay, this is the hydrophilic heads and the hydrophobic tails. So it keeps the airspace in here dry. Okay, and these are actually produced by the type 2 alveolar cells, which is producing surfactant. And the type 1 alveolar cells convert from type 2 to type 1. Once they form to type 1, they don't convert. They cannot produce surfactant any further. What I want you to basically understand is that surface tension becomes a critical value. The lung is always trying to collapse, so what surface tension you want to do is reduce the surface tension so you keep the lung from collapsing. The type 2 alveolar cells produce the surfactant, and they contain what's called dipalmitoyl phosphatidylcholine, which is basically a fat. And the advantage of surfactant is they decrease surface tension, which increases the compliance of the lung and reduces the work to expand the lung. And it promotes alveolar stability and helps keep the alveoli dry. So without it, you get reduced lung compliance, which means that you're going towards collapse rates more rapidly. You get greater alveolar atelectasis and a greater tendency to develop pulmonary edema, which is a big problem. If you have somebody who's a young little kid which doesn't have adequate levels of surfactant, when you look at a chest X-ray on them, their lungs are completely white. Okay, the reason their lungs are so white is because they actually have fluid in their lungs at that point instead of having a dry, air-filled lung. The effect of surfactant on breathing is that if you don't have adequate amounts, your work of breathing goes up dramatically. But when you have adequate amounts, you reduce the work of breathing. Okay? So without surfactant, P is large, so work is large. With surfactant, P is small, so work is small. Okay? Reduces work needed to open nearly collapsed alveoli and avoid their collapse. So without surfactant, work is large since surface tension is high. And with surfactant, work is low since surface tension is lowered because surfactant disrupts hydrogen bonds. What it comes down to is Laplace's law, okay, which is the tension is 2 times divided by the radius is the pressure inside the alveoli. Okay. For 2 connected alveoli, if you didn't have surfactant, what would end up happening is that the smaller alveoli would push all the air into the other bigger alveoli. And what you'd have is you'd have a lot less alveoli open and more collapse. But what surfactant does is it stabilizes the little guy and keeps the big guy from taking up all the gas. So it keeps, just imagine this. Imagine that you have, let's see how to explain this. I have a great picture in my mind, but I can't remember the name of this thing. There's a toy that kids have that it basically looks like a sphere. It's made out of these little plastic pieces that are all put together. And when you expand it, it becomes this huge, big sphere. Okay, you ever seen that like a geodesic dome? Okay, but when you collapse it, it still stays a sphere, but it's made much smaller. Okay, surfactant acts like that. Okay, at a certain point, it doesn't allow it to collapse anymore, so it internally stents the alveoli, even though they want to collapse at a faster rate. Okay, because they're so much smaller. So without the surfactant being there, that alveoli would collapse rapidly and push the gas to the other alveoli, which would then make it bigger. But ultimately, what you'd end up having is instead of having, let's say, 100 alveoli, you'd end up having like maybe 5 or 6 that would be open. The rest of them would all collapse. So surfactant in that way is able to protect the lung from completely collapsing, which is what you're trying to avoid at all costs. Okay? This is what the picture is trying to show you. Okay? This is based on Laplace's law. Okay? With and without surfactant. Without surfactant, okay, if you look at the ratio, okay, the P1 value is much greater in here because its radius is reduced. Okay, you'd expect that the pressure inside here would rapidly increase, which it does. Okay, and then as a consequence, the gas would basically move out this way. What the surfactant basically does is it reduces the surface tension in here, and as a consequence, the gas does not transfer to the other alveoli, and as a consequence, you don't get a fully collapsed atelectatic lung. Now, that was one portion, which is surfactant. The next portion is elasticity, or elastic properties of the lung. We don't use the word commonly elastance, and we use delta P over delta V. Instead, we use the word compliance, and after this lecture, I'm not going to use it again. So I don't really like using the word elastance and compliance. It makes students basically lost. So from this point on, we're going to talk about compliance. If anybody ever brings up elastance, just know that it's an inverse of compliance. Okay? And they should not ask you that, because if they're doing that, they're trying to cause confusion, and that's what they're trying to do. Just immediately convert that elastance into compliance, and that way you'll keep it straight in your head. Because everything from now on we talk about is compliance. Okay? Compliance is basically the slope of the pressure volume curve, which is a delta V over delta P. Okay? The normal compliance for most individuals is around 200 milliliters per 1 centimeter water pressure. So what causes a reduced compliance, which means that you have a decreased lung volume for the same change in pressure, or a change in pressure which requires a higher amount of pressure. Either one causes a reduced compliance. Anything that makes the lung stiffer, okay? So increases in fibrous tissue, such as pulmonary fibrosis, or increases in lung water, okay? So those are the only two reasons why you're going to get a decrease in compliance, okay? Which one's going to be acute and fast, which is going to be lung water. So pulmonary edema, pneumonia, okay? Anything that, pulmonary contusion, anything that brings water to the lung is going to cause the lung to get heavier, and we get a reduction in lung compliance. On the other hand, if you have a chronic problem where you have increase in collagen deposition, then you're going to get pulmonary fibrosis. That's going to also lead to a reduced lung compliance. On the other hand, what causes an increase in compliance? It could be from damage of elastin banding, which is COPD, emphysematous changes, or chronic changes where you get bronchitis, and that tends to be obstructive in the process as well, will increase the compliance to some degree. This is a normal compliance curve where you see the two components that make up the green line are the red line, which is lung compliance, which is the lung trying to collapse downwards, and the thoracic compliance, which is trying to expand outwards. And the green line is basically the amalgamation of these two different properties. So if I make the person's lung become stiffer, then I shift the whole red line downwards and cause the green line to follow. Okay? Now what you see is that these compliance curves basically dictate to you what portion of the lung will inflate a different effect or different values. Okay? If you look at the top of the lung, which will be up here, this is on the flat portion of the compliance curve. So even though this still has a lot of volume of air, the amount of ventilation effectively is minimal because you don't change much volume into that alveoli. Versus the bottom portion of the curve, which is down here, which is on the upslope of the curve, which is the bottom of the base of the lung, when you change your pressure by 10, you get a significant change in volume, which is how you maintain VQ match. Okay? If we didn't have this compliance, then air would tend to go evenly across the lung, and perfusion would be mostly at the base because it's gravity dependent. And as a consequence, you'd have a huge VQ mismatch. Okay? But because we have this compliance curve for ventilation, we're able to ventilate still the bottom of the lung more efficiently, which is where all the blood's at, which is what we want anyways. Does that make sense? Okay. Now, causes of regional differences in ventilation, the lower portion of the curve is more compliant, which is down here. Okay? So more ventilation takes place. Atelectasis does not help a flat portion of the curve, which is down here. This is the atelectatic area where the curve is flat. So it takes, that person cannot really move any gas in the atelectatic areas. Things that will cause this will be airway closure, leading to air trapping, and it makes it very difficult to re-expand that portion of the lung. And what happens with you is that when you put somebody to sleep, under general anesthesia, FRC drops, okay, which means that instead of being here on your starting point, you now drop this way. So your new point's down here. So a greater portion of your lung becomes more atelectatic. Okay, so that's normal. Now, you can partially overcome that by giving the person a little bit of CPAP or PEEP. It helps, but it doesn't completely get rid of it because the diaphragm ultimately is by far much more efficient in maintaining FRC than any other way that we can do it. Now, if you look at last three properties of the chest wall is always trying to expand outwards, and that's what's trying to maintain a certain degree of the lung from preventing it from completely collapsing. If you develop a pneumothorax, which you penetrate into the chest wall itself, then the actual lung will completely collapse inwards, and the chest wall itself will continue to expand outwards. It's actually a way to diagnose somebody who has a pneumothorax. All you do is go bottom of the feet, look up at their chest, and you'll see that the chest that's up is the one that has the actual pneumothorax in. If you do get a pneumothorax, okay, which is you get air entraining in between the pleural space and the lung, then the lung will completely collapse eventually, and you can form different kinds of pneumothorax. You can have a simple pneumothorax, which basically at that point is not too symptomatic. The person has a little bit of shortness of breath usually, slightly tachycardic, but it really symptomatically otherwise is not that significant. But if you develop into what's called a tension pneumothorax, where the pressure begins to build up inside the pleural space and begins to shift the heart away from the pneumothorax, then you get what's called a tamponade-like effect, and this person will become hemodynamically unstable and will also most likely show signs of hyperventilation. What this curve is basically doing is the same curve that I showed you before. This is the actual compliance curve, which is what I showed you in prior pictures. I just want you to know when I show you pictures that I create, they're not made out of nowhere. They actually come from somewhere, which is this. But this to me is too heavy with information, so I just switched it over to the other one to make it a little bit easier for you to understand, hopefully. FRC is basically where chest wall expansion force is equal to the lung collapsing force. It's basically, to me, is an indicator of preload to the diaphragm. That's how I look at it. Okay? It's where the set point is, where the diaphragm starts its excursion. Okay? At a certain point, the diaphragm is very efficient when it's adequate FRC. If you reduce the FRC or increase the FRC too much, both of them lead to an increased work of breathing, and as a consequence, the person will breathe faster and breathe shallower. Okay? So either way you go, high or low on your FRC curve, it's not good. Okay? It'd be equivalent to saying to you, if I give you not enough preload, what happens to heart rate? It goes up and stroke volume is low. What happens if I go high on overfilling the heart? Stroke volume goes down, but heart rate stays up. Same thing happens with the lung. Okay? The diaphragm basically does the same kind of activity as the cardiac muscle does if you underload it or overload it. And FRC basically is a measurement of that load factor. Okay? If you look at relaxation pressure volume curves, okay, the elastic properties of both the lung and chest wall determine their combined volume. At FRC, the inward pull of the lung is balanced by the outward spring of the chest wall, which is why FRC is such a critical part to understand. And then lung retracts at all volumes above minimal volume, and then chest wall tends to expand at volumes up to about 75% of the vital capacity. When you look at the next part, which is airway resistance, which is resistance through the tubes network inside the lungs, laminar flow does not occur until the 11th point in your 11th branching point in your bronchioles. So really, most flow into your dead space is turbulent. If you say to me, well, is a trachea turbulent or laminar? The answer is turbulent. It has to be. It's rapid gas moving in, and even though it's a large diameter tube, it still has a lot of turbulence. Okay? When you're looking at laminar flow, some people use Reynolds number. Okay? They use the R value. I'm not something that I memorized in this course, so I know you guys will do that in the physics course. So I'll leave it up to them to make that determination. What's important about laminar flow is the viscosity of gas changes resistance considerably. On the other hand, density does not. So density is not important for laminar flow. If you look at airflow through tubes, most of them are Reynolds number, which is turbulent flow, which is the 2 times the radius times the viscosity times the density divided by the n value, okay, where the really important factor is density. So density becomes a really big issue in turbulent flow. That's why we use Heliox. Heliox has low density gas. So you can eliminate or reduce a certain degree of the Reynolds number and decrease the degree of resistance or turbulent flow going through the actual circuit. If you look at breathing, how you actually measure pressures, you can actually, the book will kind of make it confusing for you, which is this, okay? This is volume of movement of gas, okay? Then you'll have your flows, and then you have your alveolar pressures and the interpleural pressures. The interpleural pressures follow this negative deflection downwards, but you can see the alveolar pressures only follow the sinusoidal wave pattern. Like, why the difference? Well, because alveolar pressure initially goes negative to a maximum point, but halfway through inspiration, the alveolar pressure equilibrates back to 0 at the end of inspiration. Okay? The same thing follows with expiration. You still see the greatest amount of pressure in the interpleural pressure at the end of exhalation, and the greatest amount of interpleural pressure negative-wise is during your maximal inspiratory effort, which is at the end. Okay? Then it goes rapidly back to 0. Again, more different pictures, so I'm going to keep going along. Now, the chief site of airway resistance is the medium-sized bronchioles. Okay? The greatest pressure drops occur in the first 7 airway generations. And now that's turbulent flow going through it. So the first 7 bronchioles are really, by far, the biggest changes in resistance. If you're looking at airway resistance, the highest air resistance is in the medium-sized bronchioles. And they're actually low in the very small airways because at that point you don't have resistance anymore. It's really that you're moving by Brownian movement when you get that far down. As decreases as lung volume rises because airways are then pulled open. And then bronchial smooth muscle is controlled by the autonomic nervous system. And so in other words, if you're looking at where the resistance takes place, and the answer is at the bronchioles. They're stimulated by beta-2 adrenergic receptors. They cause bronchodilation. And the parasympathetics, on the other hand, cause bronchoconstriction when acetylcholine binds to their receptor sites. The direct action on bronchial smooth muscle will depend on, to a certain degree, PaCO2. They will actually cause an increase in airway resistance as they begin to try to shunt blood away from that area. You have also your HPV factor that's important, which we're not going to talk about too much here, but maybe later down the road. Breathing a dense gas, as in a diving, increases resistance, and it shows you that turbulent flow is a big factor in normal lungs most of the time. There's also a concept called dynamic compression of the airways. Dynamic compression occurs at the end of as exhalation takes place to prevent the lung from completely collapsing. That's what it's supposed to do. If it compresses too early, then you got a problem in the sense that you cannot breathe the gas out properly. That would be example B. Be somebody that would have a tumor that would impinge exhalation from taking place properly, and that person would end up in CO2 retention as possible. Normally, the expiratory flow rate is independent of effort, and we're looking at limits airflow in normal subjects during forced expiration is what the dynamic compression does. And it may occur in diseased lungs at relatively low expiratory flow rates, which is what B is doing right here. Okay, C is a little bit of a mild COPD patient. Okay? And during dynamic compression, flow is determined by the alveolar pressure minus the pleural pressure. Okay? It's not by the mouth pressure, which is one thing the book kept saying over and over again. It's exaggerated in some lung diseases by reduced lung elastic recoil and loss of radial traction in the airways. Again, what they're trying to show you here is that dynamic compression is important for preventing lung gas from leaving the lung completely. Okay? If you're looking at pre-inspiration, normal pressures inside the trachea are zeroed out, okay? And then when a person takes in a negative pressure breath, okay, they cause the pleura to go negative, and then the alveoli become negative, and that's what gets gas into the patient. And then the person begins to exhale, where you have end inspiration, it becomes zeroed out again, and then the person exhales forcibly, and within that forcible contraction, or expiration, the actual bronchioles will begin to collapse upward. And this prevents the lung from completely emptying. Okay, that's what they call dynamic compression. That's actually a healthy thing. It's not a bad thing. The bad thing is if it occurs too early, okay, and then begins to collapse, and then the person can't exhale out anything. That's considered obstructive disease process, like asthma, COPD. Okay. Sometimes you'll do something kind of strange on a patient who has got bad COPD. You'll make him do what's called pursed lip breathing. Okay, why would you do pursed lip breathing? The reason if you close your mouth and you create positive pressure inside the trachea, then you're going to keep the bronchiole open for a longer period of time and let gas actually come out during pursed lip breathing. That's why you do that. Okay. Has anybody taught that to somebody before? Did it work? It does work. Okay, just in some patients, depending on what kind of form of COPD they have. Now, the last thing we're going to talk about today is worker breathing, okay, and this will be tied in with next week's discussion on worker breathing, which has to do with PSV and different forms of ventilators. And basically, worker breathing is a way of describing how much work is done by the lung. And work is basically equal to pressure times volume change. So when you look at your actual change in pressure or volume, it's this whole area inside here that's work. It's a lot of work, in other words. Okay? If you look at your total work done by the lung, okay, it's area 0, A, B, C, D, and 0. So this area here is all total work of breathing. Now, work of breathing can be broken down into two parts. Okay? It could be elastic workload, okay, and then viscous workload, and sometimes also into resistive workload. So which one are we talking about? Okay? If you look at where most of the area is, which is elastic force, which is O, A, E, C, D, and O, okay, that's a fairly large area. So elastic force is something that your lung is going to work hard against no matter what. And there's nothing you can do about it. Okay? If you didn't have the elastic force to work against, then your lung would not recollapse. Okay? In other words, you expand one time, and your lung would stay expanded. So you always have to work against that. Okay? So that's going to be pretty much fixed. Okay? Now, what happens if somebody has an increase in deposition of collagen? What's going to happen to workforce? It's going to increase dramatically. Okay? So if you have somebody with severely restrictive disease, what you'll see is they become emaciated, okay, because workload is going up so much. So people with restrictive disease usually are not heavy. They're thin. They're frail. They look like they have no muscle mass, because what's happening is their metabolic rate's going up tremendously to try to keep the actual diaphragm working properly, but at the point of losing other muscle in the process. Okay? Now, that being said, that's the elastic workload. That's the majority of the workload. Now, there's also viscous workload. Okay? Viscous workload is from area A, B, C, E, and A. So this little hatchet mark is due to viscous workload. And what that basically means is that you're overcoming some degree of the motion of the actual lung as it's moving in the chest wall. That's the viscous. If you look at the next one, which is resistive workload, okay, the higher the resistance, the higher the shift to the right. Okay, so in other words, it shifts this curve this way, downwards. Okay, so it shifts that way, and it causes a resistive workload can be very, very high in somebody like obstructive disease processes like emphysema or bronchitis, especially bronchitis, and asthma. Okay. Heat is a byproduct of breathing. Okay, so once you get people spontaneously breathing, now that's the area in here. Okay, that's this area here minus your total area here. That's your actual work that causes heat. So heat production is another important byproduct of worker breathing. Okay, I think we're done here. This is the last picture. Yep. Okay. So any questions about this point?